Thank you, Ruth. With that being said, I would like to introduce both Dr. Jonathan J. and Lavon Anderson, who will be joining us today. Dr. Jonathan J. is an associate professor at the BU School of Public Health, where he studies urban health and youth exposure to gun violence. He focuses on the intersection of data science and community health, examining how urban environments shape health and safety risks. Dr. J is the principal investigator of the NIMHD Career Development Award on strategies to reduce racial disparities in youth firearm injuries. He has held fellowships at the BU Harari Institute of Computing, BU Clinical and Translational Science Initiatives, and the FACS Consortium at the University of Michigan. He has also consulted on public health and safety for local governments and nonprofits nationwide. Dr. J earned his DRPH from the Harvard Chan School of Public Health and previously trained as a lawyer ethicist with a BA from Brown, a JD cum laude, and a master's in philosophy from Georgetown University. Thank you, Dr. J, for being here today. Without further ado, I'll introduce Lavon Anderson. Lavon Anderson is the housing coordinator for the VIOP program at BMC. He is dedicated to helping individuals and families impacted by violence through safety and stable housing. As a licensed real estate professional with over 5 years of experience, Lavon is committed to serving his community and guiding clients with integrity, care, and expertise. As a reminder for folks, Dr. J and Lavon will be presenting. We'll follow up with some prepared questions and it'll open up to questions in the chat. Please feel free to continue introducing yourselves and posting those questions in the chat. And without further ado, I'll let Lavon and Dr. J take it from here.
Thanks so much for the intro, Ruth and Alex. It's really great to be here. We're going to be, in a moment, I'll be talking about the VIAP, the study that we just published on the effectiveness of the VIAP program. But let me turn it over to Lavon first to talk about VIAP so everyone knows the program we're talking about.
Hello, everyone. Sorry, I'm having a hard time hearing over here. But just to tell you a little bit about the program, VIAP is a hospital-based violence intervention program founded in 2006 with the support of Mayor Menino and other local partners to address a surge in gun violence in the early 2000s. From 01 to 06, homicide was the second leading cause of death for youth ages 10 to 24 in Massachusetts. Boston Medical Center treated roughly 70% of the gunshot and stabbing victims. So how it works, when a patient is admitted to the ED with a penetrating violent injury, they're met by our violence response team, VRT, and they're they're placed on a protected list. VRT is available 24/7. They specialize in crisis intervention, psychological first aid, and they offer support navigating the hospital system and guiding people to much needed resources. Each patient is assigned an advocate and a mental health clinician. Advocates provide ongoing case management. They support clients with their daily needs, and they help patients achieve short and long-term goals. They also address hosts of other factors to social determinants of health. The community violence response team handles the mental health portion. They provide free mental health services for survivors and their families, no insurance required, and no limit on the duration of care. We have family support advocates who provide the same services as the patient advocate, but they focus specifically on the patients and family. The patient's family, I'm sorry. Family is defined by the patient and isn't limited to biological relationships. We have a visiting nurse who provides in-home care, like wound care support. They provide medical supplies, medication support, schedule follow-up appointments. And we noticed there's a decrease in the ER utilization and readmissions for patients who take advantage of that service. We also have a workforce development program that assists with job placement and educational opportunities. We have a mentorship program, which engages with youth and young adults in activities and programs that support life skills, healthy relationships, problem solving, and overall healthy lifestyle. Housing coordinators, that's my field. We help with housing stabilization, safety relocation, court mediation, financial assistance. We address credit issues and other barriers. Last but certainly not least, we have a data and research team. They collect and track key data to support violence intervention efforts, including demographics, mental health, substance use factors, among many other things to support reporting efforts for funders and stakeholders. And that's the program in a nutshell.
Thanks so much, Lavon. I'm excited to now get to talk a little bit about a study that we just published, and I will share my screen. So the research question that we had in the study was whether the work of VIAP was effective for reducing future violence involvement among survivors. And I think just one thing to really flag from the outset, you could hear from what Lavon said, which is that this is not exclusively designed as a violence prevention program. The motivation sort of originates in this need, the idea of meeting the needs of survivors, whatever they may be. And you would expect like a wide range of benefits, health benefits, mental health, economic, like just there's all kinds of ways that you could measure the effectiveness of a hospital-based violence intervention program, which I'll refer to as an HVIP. There's all kinds of ways that you can measure it, and many folks have been working on that issue. But one key question is whether HVIPs are effective for violence prevention. When we talk about why a city should have an HVIP, I think sort of inevitably one of the reasons is that it could help control violence levels. And so just to talk about, I want to acknowledge a really robust study team that we had spanning BU, Boston Medical Center, the VIAP team, and financial support from the Fund for a Safer Future. And I'll come back to that partnership as we go along because it influenced this work at many stages. But I think sort of coming back to that question about HVIPs for violence prevention, I think one thing that struck me as I sort of dug more into this field was to see that although HVIPs exist at many hospitals, right? So there's something like 60 or 70 HVIPs just within the network of the HAVI, the national organizing body. There is a real question in the scientific literature about whether HVIPs are effective for violence prevention. And so there have been a lot of published studies, but many of them are some sort of the early days of HVIP practice and were almost more like case studies. So they might have had a relatively small sample size. They sort of weren't necessarily able to follow people for long periods, and there wasn't a really compelling control group in all of those studies. So other scholars have come out and said, well, like we just don't really know that well whether HVIPs are effective. And there have been a couple of more recent studies that had sort of bigger sample sizes and stronger methods that actually failed to find any effect on violence from HVIP engagement. So this was, I think, I was struck by this discordance between sort of what I was seeing and hearing from VIAP about the depth of the work that they do and just what seems like an extremely strong model for meeting the needs of a high-risk population, and the fact that there was not evidence to support this. So as we were proposing and designing the study, what we thought was that if there's anywhere that you could find this effect, it would be at VIAP, at Boston Medical Center. And that's for a couple of reasons. The first is that it's been around for a long time. So first, the model is very mature. For example, when Lavon talks about being a housing coordinator, that's a position that many HVIPs do not have. Sort of the idea that that the services are so robust that you're getting into these specific need areas with experts in those specific areas. is the mark of a very mature HVIP. The fact that it's been around for a long time also means that they have been collecting data for a longer time. And it's not just that they've been collecting some data, they've been collecting really robust data. And so that may sound kind of technical, but it really enabled this whole study. The fact that for a very long period, they have data, strong, clean data on people's baseline characteristics from health records, their service contacts with VIAP through a Salesforce database, and then their outcomes, their violence-related outcomes, which they get through. They combine hospital records, police records, and really triangulating across sources to get strong data on outcomes. And just by the way, you might be thinking, like, when we're trying to assess whether a program works, scientists often say that a randomized controlled trial would be the gold standard. But in this case, at least at Boston Medical Center, it was clearly inappropriate because everyone at BMC who comes in with a violent penetrating injury is eligible for VIAP. And so in order to have a control group that doesn't get the intervention, you'd actually have to withhold services from people, which is would not be ethical. So instead, what we did was to look back at data from VIAP from long before, sort of the period, even before we were proposing this study, using a method called target trial emulation, which is a sort of set of statistical methods that that allow us to avoid some of the problems and mistakes that sometimes researchers make when they're using these kinds of observational data, like data that were just not collected as part of a study, but just collected in the course of routine clinical care, and line things up as closely as possible as you would if you had a randomized controlled trial. So one benefit of having so much data from BMC was that we could actually zoom in on the population that is most of interest from a violence prevention standpoint, and that's people ages 16 to 34. There's many more people in the data set, people who were offered VIAP services, including people who engaged with VIAP services, but not all of them are in the population where we are most concerned about future violence outcomes, either being a victim again or using violence against someone else in the future. We also excluded people who were experiencing homelessness at the time of their injury or who had a previous substance use disorder diagnosis. These are actually really important and high-risk subpopulations of people who were violently injured and come to BMC. But the program, this is not the population, this is a very, very high need population for which HVIPs are not primarily designed. So we excluded those data to really zoom in on kind of that prime HVIP population of youth and young adults without those particular risk factors. And we were able to follow, because we had such a long, so much data, we were able to follow people for a long time from their initial injury to see what their outcomes looked like over up to a 3-year period. And we were looking at a combined indicator of whether they were either violently re-victimized or whether they were perpetrators of violence according to police data. And so one of the big issues here was trying to figure out, what does it mean to engage with VIAP, and what does it mean to engage with VIAP at a level that we would expect to prevent violence? So one clear way of differentiating people is whether they engage with VIAP at all. Like, some people just from the beginning say, like, no, thank you. I don't need anything. Like, they don't return phone calls. Like, that is a clear population that didn't engage. So we can see the control group, the people who never engaged. And then we could say, well, if you get any service from VIAP, we're going to consider that the treatment group. So that's one way of defining whether you got the intervention. And I think that's sort of straightforward. It's easy. If you engaged at all in the first month after your injury, then we're going to follow that group forward to see how they did against the control group. The problem with that is that if you're only engaging a little, it's hard to see how that necessarily would have all of the benefits associated with these sort of intensive processes like VIAP often works with people on. So we needed to think about what would a effective dose? What do we expect an effective dose would look like? And again, that's that much more complicated because there's no set curriculum. VIAP doesn't say, you need to come see us every Wednesday for the next 3 months. They say, we are here for you as much or as little as you need, and we will continue to be here for you. So we had to look back at these data and kind of try and think about how we were going to slice it to identify that effective dose. And that was one really key place where our partnership with VIAP made a huge difference, because the study was sort of designed and implemented over the course of multiple meetings. And it was in the room that I was kind of like asking the team, what do you expect an effective dose to look like? What would you recommend that what's the engagement type or level that you would recommend if you wanted if someone wanted to sort of avoid a future violence outcome? And Lavon said, well, from my standpoint, I think what that looks like is the people who I'm seeing all the time, like consistently, whether it's every week or something like every week in that initial phase. And so that we sort of came out of that meeting with a list of a few options. And when we look back at the data, this was one that identified sort of a clear group within people who engaged. So whether someone engaged at least every other week for the first 8 weeks after their injury was this kind of discernible group in the VIAP engagers. And so that's how we defined sustained engagement. So these are 2 separate tests that we were able to run on the VIAP data. And we use statistical methods that are meant to make fair comparisons between those groups. Like there were slight differences between the treatment and the control groups on sort of what they look like demographically, how they were injured, and some other variables that we had. And we had even sort of home neighborhood variables that we were able to use to try and make that a fair comparison. And so what we found was we started with over 3,000 records, but more like 1,300 after narrowing down based on those age and other criteria for the study population. As expected, this is a group that is mostly male young adults. And in terms of engagement, almost half of the population had some engagement. That sort of, did they work with VIAP at all in the first month after injury? And it was a smaller group. It was 10% of the engagers, only 10% engaged at that high frequency or the sustained engagement level. And as you would expect, the sustained engagers had many more contacts than just the people who met that really low threshold of any engagement. So something like 5 times more contacts. And so what we found, so then we all of this is sort of heading towards these statistical models to figure out what would happen if everyone followed these protocols. And what we found was that just any treatment, sort of at the level that was actually observed among people who engaged at least once in the first month, we found 0 effect on violence-related outcomes. I mean, really remarkably, like no effect. You can see that these lines on this chart are almost identical between the people who engaged in green and the people who didn't, the control group in the sort of the black dashed line. But what we found was that for the sustained engagement group, there was far lower risk of a violence-related outcome up to 3 years. And it's something like a 50% reduction in risk at year 2 and year 3. And that is a very large effect size that is comparable to some of the biggest effects that we've seen for other community violence intervention programs in other settings. One other interesting finding was that violence-related incidents, sort of like if you start from time 0 when someone first gets hospitalized with a violence-related injury, those future violence-related outcomes are highly concentrated in the first 3 months, which is interesting and important in part because we found that the HFIP effectiveness doesn't even sort of start until you've had engagement for 8 weeks. So it kind of points to this key window for maybe some for other types of violence prevention programs that are more sort of focused in time. But just in terms of how we interpreted the findings, we noted that the effectiveness level in this study using a rigorous causal inference method is comparable to some of the sort of the individual level CVI programs that have gotten a lot of attention for being effective for violence prevention. So this, to my mind, this finding puts HVIPs in league with those, or at least VIAP, in league with those highly effective CVI programs that have gotten recognition nationally. But it really underscores the importance of dosage when it comes to violence prevention for HVIPs. It was, this slide says 11%, but it was actually 10% of people who engaged in that sustained way. And so to the extent that the goal of an HVIP is to prevent violence, that dosage is very, very important, according to the study. And there, with any non-randomized control trial, there's going to be this question about whether you're seeing a correlation and not causation, whether there was possibly selection bias. It's not clear which direction that would go in this case, whether people who engaged at a high level engaged because they could see that they were at especially high risk, or whether there was something about those engagers, those sustained engagers, that meant that they were at lower risk. We cannot rule that out using this design, but we've done everything we can statistically and methodologically to try to eliminate that in terms of all the other characteristics that we can see of those people. And I think it's important to note that even in a randomized control trial, if you want to zoom in on the people who actually sustain engagement, you're going to be modeling. There's going to be some question around selection regardless. And then just in terms of discussion, kind of going for this audience in particular, sort of thinking about what this means to Massachusetts, a lot has been made of declining gun violence rates in Boston. You can see that on the left-hand panel. These are the Suffolk County firearm homicide data from 2018 to 2024, is this sharp downward line. And on the right is Massachusetts-wide firearm homicide rates, including Boston. So this includes the Boston data, but it's not nearly as sharp a downward line. And so when we see, I think it's the fact that VIAP is effective for violence prevention suggests that VIAP is part of this picture on the left of violence going down in Boston. And it also suggests that HVIPs in other parts of Massachusetts that have, especially ones that have high gun violence rates, could be part of the solution to bending that line downwards statewide. And I'm excited to answer questions. I see a lot of familiar faces on the call.
Great. Thank you so much. Sorry, I'm trying to get my screen to agree with me to work. Thank you so much, Jonathan, Lavon, for all of this information about the VIAP program, about this study. Super excited now to dive more into some questions, both questions that Alex and I have prepared for you, as well as some great questions that we're already seeing in the chat. As a reminder to folks, if you do have questions, please feel free to add them. We'll try to get to as many as possible. But just to get us started, and even before we dive into the content of what you were talking about and the results and the work, just a little bit more about both of you and what you bring to this work also. We'd love to hear from both of you about what brings you to be doing this work, why you're so passionate about it. And I'd love to start with Lavon, please.
Thanks, Ruth. For me, I was born and raised in Boston. My community means a lot to me. I always wanted to be part of the solution, not just watch from the sidelines. Helping people and knowing I'm making a difference, that's what motivates me.
I think from where I sit in academia, which is like a very specific type of place to sit, I also feel like this is a field where research has been so stifled for so long for multiple reasons, not just because of sort of federal policy on firearms, but sort of like lack of investment from academia and universities in problems that disproportionately affect Black and Brown communities. This is an area where we need to do more. And so I think the longer I have the opportunity to work in the space, the more I feel like there's kind of this dimension of doing my own work, but also creating opportunities to sort of help build the field and bring more people in.
Yeah, thank you both for those responses. And even before we get into our next question, I just want to celebrate too the partnership between the two of you, between the VIAP program and the BU School of Public Health, and just highlight the importance of community-based programs, folks doing the deep work, academia coming together in this way. Alex and I had the opportunity to meet with both of you a few times preparing for this, and just sort of the deep partnership, respect, collaboration is something that I really want to celebrate too. So, just thank you for bringing the two of us into that work that you have been doing together. And now to get a little more deeply into just the content of what you learned and the implications, there are also some questions in the chat that touch on this too. And Jonathan, you really talked about VIAP being a part of an ecosystem of different kinds of programs and program models that when they come together can really like knit the safety net and create change in community. And so this question really gets at that, as you mentioned, and we talk about it at the coalition all the time, there's no one solution that's going to end gun violence. There's no one program that is going to solve this issue. And so if you can both talk a bit about how HVIP does fit in with other efforts like youth employment, street outreach, other kinds of programs, and how you see those different models coming together to create safety and opportunity for folks in community.
You know how they say that old saying, it takes a village. We have great relationships with other organizations who may be better equipped to handle certain situations or have better connections in certain areas. So we combine our efforts to address different sides of the same problem and do what's best for the patient, their families, and the communities. So it's all hands on deck. We always just combine our resources to be solution-based.
And I think, part of what makes HVIP so important is interrupting cycles of violence at the individual level, right? Like I think when we talk about it, when I teach it to my students, I think we sort of initially have this conversation about whether HVIPs are a public health intervention, given that they don't start to engage with someone or a person or a family until after, something really difficult has already happened. And part of why we end up concluding that they are is that those cycles at the individual and the family level are so important and so prevalent. But it's also true that, the ideal would be to keep people from getting shot or stabbed in the first place and never coming to Boston Medical Center. So I think that's one of the clear sort of ecosystem needs alongside HVIP.
Thank you both for that. And I second everything Ruth said about the collaboration you guys have given to us. Next question and final prepared question from us. For the folks that may have joined later on, what is something you want folks to take away from both this study and your broader work that you're doing in the community?
I'll start and then Lavon can get the last word on this. I wanted to comment on the partnership. I think so much of this was only possible because VIAP was so receptive to this work. Like the idea that hey, we put in this grant and got this money and now we're going to be evaluating whether your program works in a room where, everyone is convinced that everyone knows already that it works. But, there was this chance, for all they know, and for all I knew, there was a chance that we're going to have a bunch of difficult conversations about sort of not having found this effectiveness in the data. And so their willingness to kind of have me have my students, sort of work with my students on their MPH practica, like their openness to this process, I'm really grateful for, and was like really critical to. And as I said, it's like the analysis that ended up sort of identifying this key dosage issue and the effectiveness levels, like that came directly from the conversation with VIAP, and this sort of insight that Lavon had about how we should be thinking about engagement.
So sorry, Alex, I couldn't hear your question.
Oh, I just said, what is one thing for the folks that may have joined late? What is one thing you want folks to take away from your work and this study?
Okay. Simple that HFIPs work, and we need support and resources.
Thank you. Continue to support them, y'all. And that's the end of our preps questions. So we'll now be getting to the questions in the chat. Please feel free to continue posing them. We'll start from the top and work our way down, and it'll shuffle back and forth from me and Ruth. I'll start us off. Are these services only inpatient? If outpatient, how long are they followed? I believe you said 3 years, but I'll pass that to Jonathan J.
Oh, well, Lavon can comment better on sort of like the duration for a typical client. We followed them up to 3 years in the data just for the purposes of this study, because we were worried that after 3 years there was too much that too many people might have moved out of Massachusetts, or like there might have been reasons that we weren't accurately capturing their outcomes the further things went out from that initial injury. But that was just, that 3-year period was just that was like an analytical decision in the study. That's not a feature of the program. But Lavon, you can talk about sort of typically, what's the range of how long you see people continuing to work with VIAP after their initial injury?
Well, and that's tough. It varies. We definitely follow patients. We deal with patients outpatient. That's when the real work starts. The rapport is built inpatient, but there's no cap. Like, we meet them where they're at. If the client wants to come back 2 years later, no issues, we're there. There's no cutoff. But typically, based on the need, it varies. Like, housing is tough. Like, we're dealing with someone for a long time. Other situations like employment and helping them with their education needs is fairly simple. So it really depends on the need.
And I'll just put a plug in, because I would really love for us to reconvene and have a conversation about the intersection of housing and violence, and just how essential safe housing is to community safety in general. That's a topic we could talk about for hours at a time. So let's sort of put that in our parking lot and come back to it, because I think that's a really important one for us to get back to. So I'll just mention, I want to highlight something Mike McLively put into the chat about the implications for funding windows, and how this really shows that you can't fund a program for just 1 or 2 years, expect to have everything is magically fixed, and then walk away from it. And so I think that's such an incredibly important point that I just wanted to highlight as we talk about sustained investment. Sustained is long term. We can't take our foot off of the gas when it comes to actually funding the programs that we know work, because it has to be a long-term commitment to it. But then I'm going to go to the next question, which I think that you touched on a bit, which is determining if the people who have elected to the sustained involvement were self-selecting in any way. And Jonathan, I think you touched on that a bit, but if you could expand on that piece, that would be great.
Well, so we know that they were self-selecting in the sense that, no one has to engage with VIAP for any specific amount of time. Like, the people who engaged I actually would be really interested to hear Lavon talk about sort of what is it that makes someone stick with VIAP consistently over a long period. But I think we know that that group had chosen that level. They weren't randomly assigned to sustained engagement in the context of experiment. But we did not run an experiment. We were just looking back in the data. I think the issue is, from a scientific standpoint, is whether that selection biased the results. Whether, we're seeing good outcomes in the sustained engagement group because of something other than VIAP, like maybe there was just some advantage that group had versus controls. Like I said, I don't think it's so obvious that which direction that bias would cut. Like, I think the sustained engagers might have just accurately recognized that they had more needs and were more at risk. So it's possible that the results were biased in the other direction, that we underestimated the effects of VIAP. Yeah, we can't, the simple answer is we can't rule out some selection bias, but we have controlled for everything we possibly can based on individual level demographics, injury type, where they live, and those other factors.
Yeah.
Lavon, go ahead and see if you want to add something.
What makes people stick with the program, I think, is setting realistic expectations, being honest, like doing what you say you're gonna do. Most of these patients, clients, they've been let down so many times in their life, and they start to make a little progress, and then next thing you know, that the person who they've had a rapport with is gone, or program isn't there anymore. So I mean, just setting realistic expectations and plugging away, and just being honest and being genuine, and people relate to that.
Right. Authenticity really is key. I also just want to put it out there because I see comments thanking you both for your work. So I just want to pass those words of gratitude to you. And then our next question was, does no effect, I believe this is more towards Dr. J, about the study. Does no effect mean they engage as perpetrators? How did you get the information about whether the N is engaged in violence after registering for the HFIP?
I think the question is just sort of, where does the data come from about whether people caused harm? Our perpetration outcome was whether people allegedly used violence, according to a Boston Police Department arrest or other sort of investigative note. And yeah, police data has clear limitations. So we know that this is an undercount. This is likely sort of an underestimate of how much violence actually happens. It also may have people may have been inaccurately accused of having used violence. And so it's an imperfect measure. It's the only measure that I think we realistically would have access to about violence use, since there is not the ability to follow up with people and ask them whether they, ask them anonymously whether they had used violence. And so I think, yeah, we always use sort of police recorded data with some discomfort because of sort of the different biases that are encoded in it. But from a scientific standpoint, the question was, would that bias be differential according to whether someone engaged with VIAP? And we didn't think it would. So we think that, sort of the problems with those data are getting sort of evenly distributed across VIAP treatment groups.
Lavon, anything you wanted to add to that before we get to the next question?
I summed it up.
Great.
Summed it up well. Thank you.
Looking at the time, I'm actually going to combine two questions into one because they're both about, some of the variables that might have impacted the results of the study or what you saw. And one is about whether, sort of noting the maturity of the VIAP program at BMC and the number of years that VIAP has been around. Did you see that there was a higher rate of engagement, sustained or any engagement, correlating with that maturity of the program, meaning a larger share of eligible patients engaging today versus 10 or 15 years ago? The other question was about whether you saw any difference in outcomes between those impacted by gun violence or other forms of penetrating violence. If either of you want to jump in.
That first question about sort of whether engagement changed over the years, I I think we looked at it as sort of part of our broad sort of exploratory analyses, but I can't remember what we saw. We did, I mean, I don't think it influenced our results because we controlled for the year of injury. But that's a really good question of whether sort of just broadly, sort of like how has engagement changed over time with VIAP? And then the effectiveness for sustained use versus we weren't able. So for that question around whether effectiveness differed by injury type, we weren't able to slice the data any more finely than we already did. So looking at sustained engagement with sort of subsets of groups would have made those buckets too small. But I will say the sustained engagers were disproportionately people who had experienced gunshot injuries. So you can sort of, I think I feel most confident concluding that the effectiveness was for people surviving gunshot injuries.
Thank you. Lavon, did you have anything else to add? Well, then we'll move on to the next question. It's from Mark Scott, our board chair. Oh, sorry, did you have something to add? I saw you on mute.
Oh, I didn't. I'm sorry.
No worries. This question comes from Mark Scott, our board chair. He asked, does HVIP and a wider network increase sustained participation? And then does HVIP plus that network also for lower violence? And then can we measure how much partnership has increased over time? So therefore, are we more of a village?
That's a great question. I mean, it's kind of in line with this line of inquiry around sort of like how has engagement changed over time, but specifically with respect to community healing response network. I think these are the kinds of questions that you could ask from an integrated community-wide data system, or that if it were possible to track sort of the different touch points that people have with different programs over time. Huge barriers to doing that, but I know that some communities are trying, and I think we will start to see results on questions like that from other cities that are, sort of, if they are successful in integrating data from different providers.
Yeah, Mark, I would only assume so. Like I said, it takes a village and more people involved, bigger network, more resources, more support.
It's actually a great segue into another question seeing in the chat. And by the way, these questions are great. Thank you to all of our participants for putting such great energy and care into these questions. It's really making for a robust conversation. And this question is about, do you see any ways in which our mental health programs can better collaborate and support the individuals in our community? I think that's a really great conversation unto itself too. So Lavon or Jonathan, either of you want to tackle that one?
Just off the top of my head, like more availability. Like, so it's such a long wait list to get connected with mental health clinicians. And I know the second thing I'm about to say is a tough ask, but more diversity. All I hear is just clients always wanting a clinician or someone that looks like them or they can relate to. That's just a lot of feedback I get from patients.
Yeah, nothing to add except that, like Lavon said, I think that's a really good example of an ecosystem-wide need.
And one last question before we get to our action items was just how was this research supported? How did you make this magic happen?
So this was, for folks who don't know the Fund for a Safer Future, it's a sort of coalition of private funders supporting safety-related research, especially firearms research. And it was the perfect audience to pitch this study to because people working it's like a group of people working precisely in this field who would understand when we say that there are these questions in the literature about HFIP effectiveness for violence prevention. They know that that's true and what it means for the field and sort of the way that it's kind of potentially a barrier to some of the desired outcomes. And so I think it's a perfect case for we as researchers. It makes such a difference to be pitching research ideas to people who know the area, and so that funder has been really pivotal, both in our work and many others.
Thank you for that. And then the last comment about me sort of concocting several more topics for us to do lunch and learns on is a great segue to talking about our calls to action, including more lunch and learns. We always like to end with some action steps, and we'll end with gratitude too, so we'll get back to that. But our action steps for today are calls to action, plural, because we have several, are really about not just how do we show up for the buyout program for research like this, but how do we show up for the solutions that we know are working and really engage in the community in a way that moves the entire ecosystem forward. So we have a number of items that we just wanted to bring to everyone's attention before our hour is over. One being it is budget season in the Commonwealth, and the coalition historically supports a number of budget line items that fund our member organizations, that fund the solutions that we know are working, things like the Safe and Successful Youth Initiative, the DPH line item for neighborhood gun violence prevention, other DPH prevention grants, summer jobs. We know employment is a protective factor, so wanting to make sure that that is robustly funded. Recidivism, reentry supports for youth and young adults, and statewide support for homicide victims. All of those line items help to knit this ecosystem together to make sure that we are showing up deeply for the folks most impacted by gun violence. So one of our calls to action is to join the coalition in advocacy for these line items. We will be doing a literature drop on April 7th to bring information about all of these important line items to the House members. We will also have a quarterly meeting in the State House on May 12th with another literature drop on the Senate side, again, to highlight the importance of all of this work. You'll see some links dropped into the chat to learn more about those budget line items and upcoming actions to support them. And the coalition will also be highlighting that in our communications, both our newsletter, our socials. So make sure to follow us to get all that information. And Alex, why don't you give us some more of our calls to action for today?
Yes, thank you. We will also be doing a quarterly meeting with education about CVI work this May 12th. Registration link is in the chat for those. We also just want to highlight the purpose of what we all came together today. We're putting in the chat the links to both the BU article highlighting this study as well as the study in case folks want to read more about it. We also have the Mother's Day Walk with the Louis D. Brown Peace Institute coming up in May. Happy to have all of you in our team. The link will be in the chat if you want to sign up and join us in that walk. We'll be doing a Pride one as well. I can send that link via email. It's in June. And then finally, come to our next Lunch and Learn with the Trace. We'll be discussing how immigration enforcement and gun violence intersect, especially here in Massachusetts. We'll also be exploring the Trace's ICE map that tracks shootings connected to immigration rates and what it reveals about who is being impacted and where we are seeing that violence really showing up in the United States. That registration link will be in the chat. Happy to have you all come. We will also send a follow-up email to everybody with all of these links, information, and the YouTube video from this recording. And with that, thank you all. I don't know if anyone else has anything to add. Go ahead.
Yeah, please, Jonathan or Lavon, if you have other action steps that you would like to add to the list too, happy to give you a moment to do so. While you're thinking, I will also mention on April 15th, we have our Peace MVP. So we mentioned before that a couple of years ago, the VIAP program was the recipient of our Peace MVP. Every year we celebrate folks who are doing deep work in the community, moving the work of gun violence prevention forward. We are celebrating again on April 15th at Temple Israel in Boston. And our honorees are the two people who really put together the legislation we got passed in 2024, enact to modernize firearms laws. Senate Majority Leader Cindy Cream and Judiciary Chair Michael Day. So we'll put that information in the chat as well. And otherwise, I'm just going to end with some gratitude and thank again Lavon Anderson from the BIAP program, Dr. Jonathan Jay from the BU School of Public Health for all of your hard work to put this research together and make sure that we continue to lift up the solutions that we know are working in a way that really speaks to the importance of the work that's happening, the importance of funding it, sustaining it, and moving it forward. Thank you so much to the two of you and to everyone in the audience who has joined us today for this incredibly important conversation. We look forward to seeing you again very soon.